The surgical plan was flax, CTR, IOL in the bag, a sulcus, SFT. And this is a pre-operative picture, traumatic cataract, shuttlecock injury. And I'll go to the video straight away. Yeah, this is a patient history. 20 years back, he had a thing. So we planned to have a flax for him because it makes life easy for us. Doing the rexus and doing the nucleus removal, everything. You can see this flax, the rexus is already there. About week, about 3 to 4 o'clock hours. I just put some iris hooks there to support that area. And the advantage of the flax is that already it's a pre-cut, though it's a mature cataract. Yesterday also I was talking about it. The flax can penetrate even a mature cataract. Can see the cuts on the this thing, a very gentle hydrodissection and very little rotation of the nucleus. You can just pick up all the pieces without any problem. So I'm just putting 2 hooks there because the iris hooks normally have this thing on the and equal what you call traction, and I don't keep too much of traction on the bag, just enough traction for me to make sure that every time I protect the endothelium, again even rotation of the nucleus, all the pieces come into the port, and every time I come out of the eye, because this is the loose bag as well, I inject the viscoelastic like Hyalon, cohesive viscoelastic, and go ahead and do the cortical cleaning, and then I remove the iris hooks and then put the CTR in this particular patient. And then because the patient also had a traumatic mydriasis, preoperative, the pupil size was almost about 8 millimeter, and obviously I have to take care of the traumatic mydriasis as well. So I just put a single piece lens, the multi-piece MA60 lens, and into the though I have a good bag as well, but I thought I'm doing this technique for all pseudo exfoliation patients. So I thought I'll just put it in the sulcus and capture the optic into the bag. The endpoint is the ovalization of the capsular rexus margin, which indicates that the lens is locked very, very well. This lens is almost like lens in the bag, and absolutely no problem at all, no pseudophacodonosis, and the lens is also very stable in the long run. We have seen that in pseudo exfoliation, many other patients as well. And I did the single pass 4-throw pupilloplasty, and you can see here multiple throws are being done. It's a beautiful method which has been described by Amar Agarwal, and I do that to reduce the pupil size. Obviously, we have to reduce the pupil size because the patient is going to have glare because of 8 millimeter, and we have to reduce the pupil size to less than maybe 2 or 3 millimeter or so. And that's what I did at the end of the surgery. You can see here multiple throws are being done. I don't believe, of course, Amar does, but this is not an indication for pinhole pupilloplasty. You just have to make the pupil size small enough so that the patient does have very good visual acuity and no glare as well. You can see here I'm doing, and so the patient had a fairly visual acuity at the end of the surgery, and this post-operative vision of 6.9 N6, and the patient was very happy. Thank you very much for the wonderful.